Now, in the last part of the TB infection videos, we'll be discussing the treatment part and some non-tubercular infections as well. Now, the treatment anti-tubercular drugs are given in the treatment. ATDs are enlisted, in which the first line drug they are used for the treatment of drug-susceptible TB, which is known as DSTB in short, and the second line drug are used for the treatment of drug-resistant TB, DRTB, which is known as. Now, the treatment of tuberculosis aims to interrupt transmission by rendering patients non-infectious, prevent morbidity and death by curing the patients, prevent the emergence of drug resistance, and prevent relapse. To achieve the aims, the following strategies are followed. Multi-drug therapy, combination of more than one drug for rapid and effective killing of the tubercle bacilli is done. Short course chemotherapy lasting for 6 months or longer for DRTB is done. Two-phase chemotherapy, the short course is divided into intensive phase and a continuation phase. Intensive phase aims at aggressive treatment with multiple ATDs that rapidly kill the bacilli, making the smear negative, followed by continuation phase that aims at killing the remaining dormant bacilli and prevent the relapse. DOT strategy. DOT stands for Directly Observed Treatment Short Course. It is recommended by RNTCP and WHO. Here the strategies are the entire treatment course is supervised to improve the patient's compliance, and the treatment response is also monitored by sputum smear microscopy at the end of each phase. Universal DST refers to performing drug susceptibility testing for all TB patients, first performing CBNAT to determine rifampicin susceptibility, followed by line probe assay LPA. If found as rifampicin sensitive, then line LPA is performed for other first line ATDs, example isoniazid. If found as rifampicin resistant, then LPA is performed for second line agents such as fluoroquinolones, FQs, and second line injectable SLI agents. Now, the treatment regimes. The treatment should be planned only after the result of DST are available. The treatment regimes are of various types depending upon the resistance pattern. Standard regime for DSTB is a 6-month course, intensive phase, with 4 drugs HRZE for 2 months, followed by continuation phase with 3 drugs HRE for 4 months. FDC, all drugs must be given in fixed dose combination tablets as per appropriate weight bands. Daily oral regime, the FDC tablets should be taken orally once in a day. Regime for DRTB. The treatment for DRTB is complex, consists of use of higher numbers of second line agents given for longer duration. The composition of the regime depends upon the type of DRTB. Follow-up of the treatment. Patients should be followed up at scheduled intervals for the assessment of improvement in clinical and laboratory parameters. Clinical follow-up should be carried out at least monthly during treatment. Okay, now the treatment follow-up laboratory investigation for PTB cases, sputum examination is done at the end of intensive phase. At the end of every treatment, sputum smear plus culture is done for every patient. Long-term follow-up is carried out for 2 years for the completion of treatment. Follow-up for MDR-TB, sputum, smear and culture are performed every month during intensive phase and every 3 months during the continuation phase. Now, the new anti-tubercular drugs, bedaquiline and delamanid, are the only 2 drugs developed specifically for the treatment of TB in the last 40 years. Bedaquiline is the new second-line ATD of diaryl quinolines class, approved for the use as second-line ATD since 2015. It is considered as a miracle drug for the treatment of XDR-TB. It acts by inhibiting mycobacterial ATP synthase. It is strongly mycobactericidal, has no cross resistance with other STDs. Showed significant benefit in improving the time to culture conversion in MDR-TB patients. Indication is recommended for MDR-TB or XDR-TB cases which are resistant to fluoroquinolones and or second line injectable drugs. Now, in this flowchart, we summarize the treatment regime. All cases of TB undergo CBNAT. If it is rifampicin sensitive, then of course first line LPAs are given, like isoniazid. If isoniazid is sensitive, then initiate DS-TB regime, and if isoniazid resistant, then initiate H monopoly regime. Now, if the bacteria is rifampicin resistant TB, then second line LPAs are given. The second line, FQ and SLI sensitive, initiate MDR-TB regime. Fluoroquinolone resistant but SLI sensitive, initiate XDR-TB regime. FQ sensitive and SLI resistant, initiate pre-XDR-TB regime, and FQ resistant and SLI resistant, initiate XDR regime. In this, FQ stands for fluoroquinolones, SLI is second line injectable, CB-NAT is cartridge based nucleic acid amplification test, LB is line probe assay, MDR-TB is multi-drug resistant TB, and XDR-TB is extensively drug resistant TB. Now in this table we can see the anti-tubercular drugs used for treatment of drug susceptible TB, DSTB, and the drug resistant TB, DRTB. For DSTB, first line agents are isoniazid, rifampicin, pyrazinamide, and ethambutol. For DRTB, we can use fluoroquinolones like levofloxacin, moxifloxacin, gatifloxacin. Second line injectables like amikacin, cepromycin, kanamycin, and streptomycin. Other second line agents like ethonamide, prothionamide, cycloserine, terazidone, linezolid, clofazimine, etc. Group D add-on agents not a part of the core MDR-TB regime. They can be first-line agents like pyrazinamide, ethambutol, high-dose isoniazid. In D2 come the new agents like bedaquiline, delaminate, and in D3 the other agents like PASP, para-aminosalicylic acid, imipenem, cystatin, IPM, CLS, and meropenem, amoxicillin clavulinate, or thioacetozone. Now the drug regime for tuberculosis depending on the pattern of resistance. For DSTB, when there is no resistance, H, R, E, and Z, as we have seen the abbreviations above, can be used in intensive phase, and HRE can be used in continuation phase. Now for H mono or poly, in which it is called as H mono or poly DRTB regime, in which levofloxacin, KM, REZ, these can be used in intensive, while continuation phase does not require the KM. Okay. Now MDR-TB or RR-TB, it has a short MDR-TB regime and a conventional MDR-TB regime. Similarly, pre-XDR-TB has a regime for MDR-RR plus resistant fluoroquinolone class, then a regime for MDR-RR plus resistant SLI class, and XDR-TB has a regime for MDR-RR plus or TB plus R or FQ and SLI class. Okay. Now please note, if the intensive phase is prolonged, then the injectable agent is only given 3 times a week with an extended intensive phase. Pre-XDR-TB resistance to either fluoroquinolones or second line injectable agents, but not both. RNTCP does not use this terminology. MFXH refers to high dose of moxifloxacin. Shorter MDR-TB regime is recommended for pulmonary TB, pleural TB, and TB lymph node. Conventional MDR-TB is recommended for extrapulmonary TB, extrapleural TB, and TB lymph node, and in pregnancy. The duration of treatment is given, of course. If kanamycin is found resistant, then add capromycin if the regime is found susceptible. DSTB stands for drug sensitive TB. Okay, MDR-TB is multi-drug resistant TB, RR-TB is rifampicin resistant TB, XDR-TB is extensively drug resistant TB, RFQ is resistant to fluoroquinolones, RSLI is resistant to second line injectable agents, H is isoniazid, R is rifampicin, E is ethambutol, Z is pyrazinamide, LFX is levofloxacin, KM is kanamycin, MFX is moxifloxacin, ETO is ethionamide, CFZ is clofazimine, HH is high dose isoniazid, and CS cycloserine, LSZ linezolid, PDQ bedaquiline, and CM is capromycin. So all these can be used for the treatment of tuberculosis. Drug dosage also, you can see the weight categories described. Like in intensive phase, 2, 3, 4, and 5 tablets are given for progressively 25 to 39, then 40 to 54, 55 to 69, and more than 70 kgs. While in continuation phase also almost the same number of tablets are given. In intensive they give HRZE, and continuation we give HRE. Fixed dose combination FDC tablet contains, in intensive phase, contain isoniazid 75 mg, rifampicin 150 mg, pyrazinamide 400 mg, and ethambutol 275 mg. While FDC tablet of continuation phase contains isoniazid 75 mg, rifampicin 150 mg, and ethambutol 275 mg. Okay, so now continuing that, bedaquiline, it is contraindicated in pregnancy age less than 18 years, and regime bedaquiline containing regime should contain 4 other second line ADTs depending upon the sensitivity. Next drug in the line was delamanid. Delamanid is a new ATD introduced in 2018, derived from Nitromidazole class. Mechanism of action: it acts by inhibiting mycolic acid synthesis of bacterial cell wall. Indication: it is approved for use in treatment of DRTB, MDR, XDR, mixed pattern DRTB in a combination regime. Exclusion criteria: delamanid should not be used for following children under 6 years, pregnant and breastfeeding women, and patients with prolonged QT interval, and if hypersensitivity develops, then also it should not be used. Current status in India: 7 states have been identified as initial sites for the production of delamanid under RNTCP: Punjab, Chandigarh, Rajasthan, Karnataka, Odisha, Kerala, and Lakshadweep. Now, resistant to anti-tubercular drugs. Drug resistance is the most worrisome aspect of management of tuberculosis. Development of drug resistance may occur due to primary or pre-treatment drug resistance develops in a strain infecting a patient who has not previously been treated. It mostly occurs due to the infection of an individual by drug-resistant strain. Primary resistance accounts for minority of the cases, while the acquired resistance, which is secondary or post-treatment, it develops when the infective strain is initially sensitive, becomes resistant later. It is usually due to inappropriate or inadequate treatment. This is much more common than primary resistance. Mechanism of drug resistance. Mechanism of resistance in tubercle bacilli is due to point mutation in the genome of M. tuberculosis, which occurs at the rate of once in 10 to the power 8 cell divisions. Rationale of using multi-drug therapy. The most worrisome aspect of chemotherapy is the development of drug resistance, especially when monotherapy is used. This can be effectively checked by multiple drug therapy. Incidence of resistance to one drug is independent to that of other. Hence, the probability of a strain to be resistant to two drugs is much lower than when these drugs are used independently. Failure to adhere to the multi-drug regime is the most important reason for the development of resistance, which may be due to prolonged duration of the regime, poor compliance of the patient, development of toxicity to the drugs, and improper supervision and follow-up. Now, the resistant to antitubercular drugs: monoresistant defined as resistant to first-line drug ATD only. Polyresistant is defined as resistant to more than one first-line ATD other than both isoniazid and rifampicin. Rifampicin resistance RR, defined as rifampicin resistant with or without resistance to other ATDs. It includes any resistance to rifampicin in the form of monoresistance, polyresistance, MDR or XDR. Multi-drug resistant tuberculosis, MDR-TB. Definition: MDR-TB is defined as resistant to both isoniazid and rifampicin with or without resistance to other first-line ATDs. Epidemiology world: in 2018, 3.4% of the new and 18% of previously treated cases are MDR-RR-TB, with highest proportions in countries of former Soviet Union. The drug resistant genes present with M. tuberculosis, like isoniazid drug resistant genes, are INHA, CATG, and alkyl hydroperoxide reductase AHPC. Rifampicin resistance is due to RNA polymerase subunit B. Pyrinamide resistance is due to pyranamidase. Ethambutol resistance due to ribosomal protein subunit 12. Streptomycin resistance is due to ribosomal protein subunit 12, 16S ribosomal rRNA, and aminoglycoside phosphotransferase gene. Fluoroquinolone resistance is due to DNA gyrase, GYR A and GYR B. India 2018 MDR-TB rate in India was 6.19% in all TB patients, 2.8% of all new TB cases, and 11.6% of the retreatment cases. Treatment of MDR-TB. The RNTCP regime comprises of an intensive phase of 4 to 9 months with 6 to 7 second-line agents, followed by continuation phase of 5 to 18 months with 4 second-line agents. DOTS Plus program is initiated by RNTCP in the year 2000 to cover the diagnosis and treatment of MDR-TB cases. Extensively drug-resistant tuberculosis, XDR-TB. Definition: they are MDR-TB cases which are also resistant to fluoroquinolones, levofloxacin, moxifloxacin and gatifloxacin, and at least one second-line injectable agent like amikacin, caperomycin and kanamycin. Epidemiology in India 2018 XDR-TB accounted for 1.3% in all MDR-TB patients, 2.3% in new and 0.91% in previously treated patients. Treatment of XDR-TB is extremely difficult. XDR-TB has a very rapidly progressing clinical course with high mortality. The RNTCP regime is even more prolonged with the use of higher number of second-line agents. Pre-XDR-TB refers to resistance to either fluoroquinolones or second-line injectable agents, but not both. In 2018, Among MDR TB cases, 21.8% were resistant to any FQs and 3.6% were resistant to any SLI agent. The RNTCP regime we have seen. Now, the global and national TB programs. The End TB strategy WHO in 2016, the WHO has launched the End TB strategy by 2035 in order to end the global tuberculosis epidemic. It has the following objectives: about 95% reduction by 2035 in number of TB deaths compared with 2015, about 90% reduction by 2035 in TB incidence rate compared to 2015, and 0% TB affected families facing catastrophic cost due to TB by 2035. Every year, March 24th is observed as World Tuberculosis Day globally. The theme of the World for Tuberculosis Day 2020 was "It's Time to End TB." Now, the revised National Tuberculosis Control Program (RNTCP). The Government of India has launched its health program in 1992 in collaboration with WHO and World Bank. In 2020, RNTCP has been named as National Tuberculosis Elimination Program (NTEP). The main strategies of RNTCP are detecting more than 70% of the estimated cases by quality sputum microscopy, cure rate not less than 85%, involvement of NGOs, non-governmental organization, implementing DOTS, directly observed treatment short course, a community-based treatment and care of TB patients under supervision, and implementing DOTS Plus for detection and treatment of MDR TB. Structural organization from center to periphery, the TB laboratories under Government of India are designated as follows: Central TB Division, National TB Reference Laboratory, State TB Division, Intermediate TB Reference Laboratory, Tuberculosis Unit, District Microscopy Center DMC. The four National TB Reference Laboratories are National TB Institute Bengaluru, the National Institute of TB and Respiratory Disease New Delhi, National Institute of Research in Tuberculosis Chennai, and Jalma Institute of Leprosy and Other Mycobacterial Disease Agra. National Strategic Plan of India 2020 to 25. In parallel to WHO, Government of India has initiated a national strategic plan aiming at elimination of TB epidemic with a vision of TB-free India with zero deaths, disease and poverty due to tuberculosis by 2025. Nikshay is a web portal introduced in 2018 for surveillance of TB. Government of India has made it mandate for all healthcare providers, both government and private sector, to notify all the new TB cases through this web. 99 dots is named so very high success rate of about 99% is expected by this remote in built techno supervision. It's a low cost mobile phone based technology available since 2016 that enables real time remote monitoring of daily intake of treatment of TB HIV co-infected patients. Vaccine prophylaxis against tuberculosis, Bacillus calmette guerin vaccine BCG. BCG vaccine was developed by Calmette and Guerin. BCG strain in India, WHO recommended Danish 1331 strain of BCG. It is prepared by Central BCG Laboratory, Guindy, Chennai. Okay, now the reconstitution of BCG. BCG is available in lyophilized form, should be reconstituted before administration. This is done by using normal saline as diluent. Distilled water is never used as it is irritant. Once reconstituted, it has to be administered within 1 hour. Administration of BCG. 0.1 ml, 0.1 mg TU of BCG vaccine is administered above the insertion of the left deltoid by intradermal route using a 26 gauge tuberculin syringe. Phenomena after BCG. If BCG is properly injected intradermally, then the following phenomena develop at the inoculation site. After 2 to 3 weeks, papule develops. After 5 to 6 weeks, shallow ulcer develops, which is covered with crust. After 6 to 12 weeks, permanent tiny round scar of 4 to 8 mm diameter is formed. And after 8 to 14 weeks, Mantox test becomes positive. If overdose is given, the lesion or scar becomes larger and irregular in size. Protection, efficacy. Many trials have shown that BCG has a variable efficacy of 0 to 80%. Duration of immunity lasts for only for 15 to 20 years. Though BCG may not protect from the risk of tuberculosis infection, it surely gives a protection to infants and young children against the development of complications such as tuberculous meningitis and disseminated tuberculosis. Complications following BCG. The most common complications include ulceration at the vaccination site and regional lymphadenitis. Rarely, keloid or lupus lesion and osteomyelitis may develop. Very rarely, non-fatal meningitis, progressive tuberculosis and disseminated BCG infection, BCGitis are reported in people with low immunity. Indications of BCG: direct BCG is directly given to the newborn soon after birth. This strategy is followed by most of the developing countries, including India. If not given at birth, it can be given later, maximum up to 2 years. Indirect BCG is given after performing the tuberculin skin test. Contraindication to BCG include HIV positive child, child born to AFB positive mother, child with low immunity, generalized eczema, and pregnancy. Other uses of BCG are: BCG induces non-specific stimulation of immune system, thus provides some protection against certain diseases such as leprosy and leukemia. BCG has been tried as an adjunctive therapy in malignancies such as bladder carcinoma, oncotype strain of BCG. VPM 1002, it's a recombinant BCG vaccine under phase 2 trial 2017. It is prepared by replacing the urease C encoding gene from Listeria monocytogenes, which improves its immunogenicity, promotes phagolysosome fusion. Chemoprophylaxis, the treatment of selected high-risk tuberculin reactors, that is, people with latent tuberculosis, aims at preventing active disease. Isoniazid or ethambutol for 6 months have been tried. However, chemoprophylaxis has several shortcomings, such as it is expensive, risk of developing tuberculosis is minimal in tuberculin reactors, and side effects of the drugs are there. Hence, INH preventive therapy IPT can be restricted to limited indications such as adults with HIV who are unlikely to have active TB, children with HIV who have no TB symptoms and who are unlikely to have active TB, all children with HIV who have successfully completed the treatment for TB. Okay, now coming on to the non-tuberculous mycobacteria infections. Non-tuberculous mycobacteria were formerly called as atypical monobacteria or monobacteria other than tubercle, bacilli, mott. NTM are a diverse group of mycobacteria that are isolated from birds, animals, and from environmental sources such as soil and water. They are opportunistic pathogens occasionally associated with human infection. Man-to-man transmission is not known. Saprophytic mycobacteria are isolated from soil, water, and other environmental sources. They do not cause any disease in humans and are distinct from NTM. Examples include M. fili from grass and semigmatis from smegma, a common contaminant in the urine. Classification of NTM, non-tuberculous mycobacteria, have been classified into 4 groups by Runyon based on pigment production and rate of growth. Photochromogens, they produce pigments only when the colonies are exposed to light. This group contains the following pathogens: M. marnium, it is acquired from water sources, fish tanks, swimming, and enters through minor trauma. It typically causes papules or ulcers known as swimming pool granuloma or fish tank granuloma. The Runyon's classification of non-tuberculous mycobacteria can be seen here. Runyon group photochromogens produce pigments only in light, species M. marnium, M. asiaticum, etc. Scotochromogens produce pigments both in dark and light, M. scrofloicum, M. sclugi, M. gordoni, and M. silatum, M. flavescens, etc. Non-photochromogens do not produce pigments like M. avium intracellular complex, MAC, M. xenopi, M. ulcerans, etc. M. paratuberculosis. Rapid growers grow within a week, M. chelone, M. forticum, M. smegmatis, M. abscessus, etc. M. asiaticum is a rarely isolated with pulmonary disease and bursitis. M. simi was originally isolated from monkeys. It is principally isolated from pulmonary lesions. M. canasi, it causes chronic pulmonary disease resembling tuberculosis. M. genovese grows very slowly and rarely causes infection in patients with advanced HIV. Scotochromogens, they produce pigments yellow, orange, red even when cultures are incubated in dark, but intensity of the color may increase on exposure to light. M. scrofulaceum causes scrofula, cervical lymphadenitis in children. M. gordone, often found as commensal in tap water, is a common contaminant of clinical specimen. It is rarely isolated from pulmonary specimen, however, its pathogenic potential is doubtful. M. slogai behaves as scotochromogen at 37 degrees Celsius and photochromogen at 25 degrees Celsius. May occasionally cause pulmonary disease and bursitis. M. silatum, rare cause of pulmonary infection. The non-photochromogens, they do not produce pigments. Examples include M. avium intracellular complex, MAC. They comprise of 2 related organisms, M. avium batibacillus, isolated from birds, and M. intracellular. They are opportunistic pathogens, especially in HIV-infected people with low CD4 T cell count less than 50 per microliter. MAC can cause various manifestations: lymphadenitis, respiratory infection, and disseminated disease. Xenopy has been isolated from hospital water supplies and associated with nosocomial outbreaks. It is found as a commensal but rarely causes pulmonary disease, especially in HIV infected people. M. ulcerans, it typically produces painless ulcers and nodules called as Buruli ulcer, found mainly in the tropics. It can also cause osteomyelitis and limb deformities. M. malmonis can cause pulmonary disease and rarely lymphadenitis. M. paratuberculosis, John's bacillus, mainly causes disease in the cattle associated with the pathogenesis of Crohn's disease, but this link has not been proved yet. Lastly, the rapid growers, the group of NTM grow in culture within 1 week of incubation. Examples include M40 for uitum and M. kilone. They cause post-trauma injection, abscess, and catheter-related infections. M. abscessus can cause pulmonary infection. Okay, now the lab diagnosis: specimen, sputum, lymph node, aspirate, pus, or exudate biopsy from skin lesions are the usual specimens depending on the type of infection. Microscopy by Zn staining shows red acid-fast bacilli which needs to be differentiated from M. tuberculosis. Culture on LG media: several species of NTM grow well on LG medium, however, a few grow sparsely. Pigment production for the LG media are incubated in dark and light separately for distinguishing between photochromogens and scotochromogens. Identification: species of NTM can be identified from M. tuberculosis complex by negative for MPT64 antigen by ICT, suggestive of NTM infection, differentiating it from M. tuberculosis. While biochemical tests less commonly used now, a new method like Malditoff matrix assisted laser desorption, ionization, time of flight, and molecular methods such as PCR preferred method for species identification of NTM. Now, the clinical manifestation of pulmonary infection are like organisms like MAC, M. concise, Xenopy, etc. Lymph node infection is by MAC, M. scrofuluaceum causes scrofula, and M. malmonis. Cutaneous infection are by M. marinum causes swimming pool or fish tongue granuloma. M. ulcerans causes Buruli ulcer. M. abscessus, M. fortunium, and M. kilone cause injection abscess, and MAC is also there. Disseminated infection by MAC and M. canci. Now, the treatment by non-tuberculous mycobacteria infection, just as in tuberculosis, NTM infections are treated with multi-drug therapy and are associated with the emergence of drug resistance and relapse. M. avium intracellular complex, M. canci, and M. marinium infections often require multi-drug therapy with macrolide, clarithromycin and azithromycin, ethambutol, and a rifampin or rifabutin. NTM are resistant to most of the first and second line anti-tubercular drugs. Okay, so this completes our chapter. Now the expected questions. First, a case. Rajesh, a 20-year-old male, was admitted to hospital with complaints of low-grade fever, loss of appetite, weight, and chronic cough with expectoration for past 6 months. Sputum examination revealed long, slender, beaded, acid-fast bacilli. Clearly a case of tuberculosis. Okay, now the diagnosis, pathogenesis, and lab diagnosis, drug resistance, all that we can write. Now, short notes on BCG, MTR, TB, non-tuberculous mycobacteria infection you can write. Now, the MCQs: positive tuberculation skin test is indicated by an induration of more than 10 mm in diameter. How much bacillary load in sputum is required for the effective transmission of M. tuberculosis? Almost more than 10,000 bacilli per ml are required. Survival of M. tuberculosis inside the macrophages is due to the inhibition of phagosome lysosome fusion. Okay, so this completes our tuberculosis. Next we'll be starting with pertussis. Stay tuned. Thanks for watching. Like, share, subscribe.